unfortunately, we're also rationing something that I really hate we have to ration as a society, and that's housing, because the demand always far outpaces the supply that we have available of it. So, that's part of the reason we're ranking and prioritizing people. And to me, that's kind of sad when I operate from the premise that housing should be a fundamental, human right.
Welcome to today's podcast episode. Actually, this is our 50th. Carey, it's a special episode to have you here. We're so excited to have you. And for our listeners, Carey has an extremely important role here in our community, serving as healthcare for the Homeless Supervisor at the family health centers here in our community. And that also includes what we're going to talk about here in a bit, what is called the Common Assessment Street Outreach Team. Carey, great to see you on this Monday morning.
Thank you. Happy to be here today.
It's wonderful. It's certainly wonderful to hear from you today and to have you here. And I want to start off with a bit of a personal question. You are friends and go back almost 2 decades with our CEO, Executive Director Jennifer Clark, and she had asked us to ask you about what I believe to be was a pet adoption experience. Your cat, Baby. Tell us. I've been told to ask you about that. Tell us a little bit about that.
Sure. And I guess Jennifer actually knew Baby pretty well. Baby was an orange cat who I met around 2010, one of our first permanent supportive housing clients at Phoenix. So was a formerly homeless person living in a small apartment and had adopted this orange cat, very large, like 20-pound plus cat named Baby, that was just his world. And unfortunately, I knew them for a couple of years, and unfortunately he fell terminally ill, and that was one of his last wishes, that was someone adopted Baby. And his case manager spent a lot of time, and the man unfortunately passed away before the adoption was complete. But she made that promise, and I was basically the one talked into taking Baby, and I already had one cat at home already. Yeah, around 2012, I adopted this 20-pound plus orange cat that had this really gruff meow, and came into our house and learned to coexist with my other cat, Pete, and we had Baby for 7 years. Until he fell ill too. And we don't really know how old he was, but we think he was probably close to about 15 years old. He did get down to, I think, 15 or 16 pounds. So I think he had a good, I think he was sad to part from his first home, but I think that we were able to give him a good quality of life, and he was able
had some Garfield mannerisms then?
Yeah, total Garfield lookalike, inspiration. So yeah, that was social work can extend to pets as well.
Both you and Jennifer are so important to our community. You've spent, I would say, if not all of your career, the vast majority of it so far, in homeless services. Where did the passion come from to serve in this way in our community, and in such an important way in our community?
Like a lot of things in life, I think it found me. My background is really not in social work or social services. It's in public policy, and that's what I spent most of my 20s studying in graduate school. And for those of us who remember, like around 2008, like times were really, really tough, and there weren't a whole lot of jobs out there. And I was actually a teaching assistant for a statistics class, and one of my students that I'd been tutoring said, I'm interning at this organization, and they really need someone that understands how databases and statistics work for this grant they just got and they're evaluating. And would you be interested? And I thought, well, a job, yeah, sure. And housing had definitely been my background, so I should say that as well. Like I've always been very interested in housing policy, but I had really not gotten into homelessness too much. So I interviewed for the job. And luckily got it. And I didn't know. I kind of thought maybe that'd be something I did for a couple of years and, moved on to something else. And I did do a lot of statistics, a lot of data analysis, which I do now, and enjoyed that a lot. But I also discovered that so much beyond that, because, of course, there's the qualitative side to the work we're doing, and the people that we serve are so unique, and their challenges and the struggles they've been through are. So it was really hard to leave it. And we'll talk a little bit about family health centers later, but it's just a great environment to work in, with a wonderful mission, and treats their employees so well. So, it just, it become my career, not necessarily intentionally, but it has.
What drew you to housing policy initially? And just going into that.
Sure. Yeah. I come from a long line of home builders, and my dad is a semi-retired contractor now, so I was kind of around that all of my life, and I was also very interested in the finance aspect and understanding how affordable housing worked, and got into urban planning from there. So just really holistically, I think, like my whole life, like there's been some aspect of like the importance of housing in there. So it just kind of made sense, like going off of my social sciences background in undergraduate school, that I just like kept diving into it, and that eventually led me into homelessness policy.
Well, you're bringing me back to college. I got my degree in accounting, but statistics was the hardest class always. It was. Now you have AI, and you could just.
It's a different language, and I'll be honest, it took me a couple of years, and I had one professor who just like knew how to speak the language, and once he's kind of put his spin on it, it all made sense to me. But yes, it is a very hard language, I think, to break into, even if you're a numbers person.
Well, talking about that background, and Tony mentioned urban affairs, and you did as well. You have I understand that you have a PhD in urban studies and affairs, and your thesis, your doctoral dissertation, 200 and something pages, entitled "Housing First, Neighborhood Second: The Role of Housing and Neighborhood Characteristics on Residential Stability in Two Housing First Projects." Tell us about that research that you did and kind of what you learned from that.
Sure. So interesting story. This was actually the second dissertation that I started, and I luckily finished this one. I started working for family health centers just as I had finished my coursework. So I was really in the dissertation phase, and I had wrote a proposal for a dissertation already, which is on the community development block grant program. But then I got really immersed in my job, and I didn't work on my dissertation for a long time, which is something that happens. And one day my advisor said, "I don't think you're going to finish this dissertation you started." She said, "But I think you are really into what you're doing now, and you have some data there, so why don't you use it?" And luckily I took her advice, and I actually finished up like pretty quickly after that, after having drug it out for a few years. And I went into the data that I was at that time gathering as a program evaluator for our SAMHSA grant, and also worked with one of our fellow grantees in Cincinnati who was operating a very similar program. So that's why it says two housing first projects. But of course, we were always in the housing. We provide permanent supportive housing, like St. Vincent de Paul does, for people formerly homeless people to have a stable home and the supporting services they need to be successful in there. But beyond that, I was always interested in, where's the unit? When you get into renting with vouchers or, properties that agencies have developed, there's factors that determine where they are. A lot of times these units may be in more poverty affected neighborhoods. They may be in more segregated neighborhoods. They may be in neighborhoods that lack access to services. So I spent a year or so looking at that aspect of the program. I did a lot of geocoding and actually mapped out where our participants were living all over Jefferson County, looked at different demographics, data from the census, other factors, just trying to determine what their neighborhoods look like. And I think largely what I can say I found is, what we would agree as housing consumers ourselves is choice really matters. People want to be in good, stable neighborhoods. They want to be close to grocery stores and be able to walk places. They don't want a lot of crime and, they don't want to be around crime. I think it's really important. A lot of people are kind of reintegrating after having been homeless for a long time, and a lot of them want a fresh start. It's also part of their recovery, maybe from an addiction or from mental illness as well. So I think, what we found the big thing is the impact of the community and the neighborhood can promote stability in terms of that person either not falling back into homelessness or not continuing to move again and again and having to start over and go through the financial turmoil and all the other stress of moving and trying to find an optimal unit. So yeah, it was a great experience to finally wrap up my graduate studies and apply it with the work that I had been doing.
Yeah, I'm curious. You just mentioned, community can provide stability to avoid kind of going back into homelessness, and you've worked in homelessness for the last, almost 2 decades, since 2010. What have you learned about this space? I mean, obviously, it sounds like housing policy kind of is interwoven into your story, and that led you to affordable housing. What have you seen kind of over these last 15 years, learned in the space you're in?
So I started out working with our permanent supportive housing program. And as you said earlier, my job for the past 12 years has been, I really helped implement what we call our common assessment or our coordinated entry team for the community. And since I've done that, I think just the diversity of people who are unhoused, that's something that people don't really think about, even people in the field, because a lot of practitioners are very specialized. So they may only work with families, or they may only work with veterans or people dealing with addictions, but it really is such a wider spectrum than that. Like, it affects people on so many different levels, especially as housing has just become a lot more unaffordable. So, we see a lot of families with children, which is always really sad and hard to see. We see younger and younger people now. And then when I say younger, I mean, 18 and 19-year-olds who are out on the street for various reasons as well. We're seeing a lot more of the international community now unhoused. It seems like when I started doing this, we never needed an interpreter, and we're getting Spanish interpreters or interpreters for African languages now. As I think we have people who have come to Louisville to resettle and have unfortunately not had the same safety nets they've had in the past, or had the same family resources they've had in the past. So it's there's a lot of stereotypes for homelessness, but really it's the gamut of people that we see. I mean, I had a parent of a young person struggling with severe mental illness on the phone this week, and from the call, it seemed like he had grown up in a pretty privileged and supportive household, but was struggling with a mental health issue that's really put him and his stability, to stay off the streets in jeopardy. So I think it can, really affect anyone on a much more broader level than you think, and it can't be tied to one core cause, which I think we often want to do just because it makes it simpler and easier for us to understand.
Yeah, we did a story recently on a gentleman who has been over at our men's shelter, and I think he's at the tail end of where he'll get housed soon. But he lived in a nice home in Crescent Hill, owned his own company, where he did some commercial cleaning for a couple of decades. And then COVID really just wiped it out. And he had some physical challenges as well around that time. So it amazes me the more we tell stories here at St. Vincent de Paul that it is so diverse, and there are a number of reasons that people fall into homelessness. Do you find, because you mentioned earlier that, people fall back into homelessness based on whether the community is supportive? I don't know what the statistics are, but do you find it's a lot harder when someone enters homelessness to get out of it?
Yeah, absolutely. And not to return to it, I read I supervise social work students at Kent School at University of Louisville and Spalding both. And we recently read the book Evicted by Matthew Desmond, which is a collection of ethnographies he did about eviction in Milwaukee in 2008 during, what was a financial crisis. But even though it took place that long ago, the things you read about are really relevant, and it really helped me understand how cyclical it is, because I tend to work with people who are living in the moment in homelessness, but all the adversity that they face, in substandard housing, in housing that they're always like one paycheck away or one disability check away from, losing again, that they have families and friends that may do things in their units that are, were not directly their calls, but then they, unfortunately they're the victim from that and they get evicted. So the households in this book Evicted, which, included a pretty large diversity of people living in poverty in Milwaukee, by race, family status, different barriers they face, but, all of them just like really continued to struggle, and it would follow some of these families from apartment to apartment. And, it was just, they were always at risk of going back. And I think that that's only, for a few reasons, that's only gotten harder. You mentioned COVID. COVID was a big game changer in this field. At that time, a lot of resources came out to help people. I think our government really tried to assist people because they knew they were struggling, and that's wonderful. But then those resources have since dried up. They expired. And in the interim, inflation has just been out of control. It's housing especially is more expensive than ever. So it's, unfortunately, since this book, was published in 2016, and most of the stories in it go back way further than that, I don't think a lot's changed, and that it's just a really hard housing market to survive. So if you have evictions on your record that make it hard for you to find places, if you're, renting in a market that really sometimes exploits people in those situations, it's just hard to find stability again.
Yeah, I think it's the time that I spent at St. Vincent de Paul, there were a lot of things that I learned that I was not aware of before actually experiencing it as closely as I did in that role. And I came to the realization that, obviously there's a lot of different reasons why people find themselves homeless, but what I didn't necessarily appreciate before then, and can actually relate it back to my own personal experiences and family and all that, and that relational poverty is real. And, you mentioned, Tony, the individual that is in St. Vincent de Paul shelter right now. And there's folks that just suffer from that they just don't have that network to help them get beyond whatever their issues are. Now, whether they burned the network or didn't or whatever, that happens, that happens, and it's a reality. We had a very personal situation with my wife's brother, who has since passed. But, if it wasn't for his family network with the challenges that he was faced with, regardless of his economic status, when his parents passed, my wife's mother and father, if it wasn't for the the siblings, he would have been a statistic that would have ended up in an unfortunate situation. But so it's real, and it's interesting, Carey. When House Bill 5 came out, one of the things that I did was invite the bill sponsors to come out and visit St. Vincent de Paul. And for those that don't remember House Bill 5, it essentially, I'll just put it in this term, criminalized homelessness. And I didn't know any other way to try to get some level of advocacy other than to say, come on and see what we're doing, see what it is that is going on with the support that we're getting from so many different places. And while I didn't necessarily change their vote on the bill, it changed their view on why folks are finding their way to us and all the different circumstances, and that a lot of the myths. It's almost like you want to become a myth buster.
Oh yeah,
be a myth buster and say, no, that's not true. That's not true. Or this isn't true, or this is true. But to see it and touch it and experience it is the best way that I know to start to create some level of understanding and some level of empathy. Because without it, it's hard to really kind of turn those wheels.
Well, and the other thing to understand, and that you bring up a great example with House Bill 5, is it's kind of the assumption is that people are out loitering on the street when they could go to a shelter. And St. Vincent de Paul and a lot of other agencies are doing wonderful things. I see people come in to our office all the time asking, how they get into the shelter, but from your time there that shelter is full every day and people have to be turned down. And the reality is there's not enough shelter. And I work there's a special court docket that was a result of House Bill 5 to help people who have been cited, for being outdoors, sleeping, to kind of help mitigate their charges and hopefully, divert them from fines or anything else. But one thing I noticed this winter were people, we have what's called Operation White Flag. In the winter when it's really cold, the shelters expand their capacity, and I had people who were going into shelter usually at Wayside when they could, and then the days they couldn't, they were outside and they were getting citations. So it is a myth that, some people do choose not to go to shelter. That's true. But a lot of people, would if they had a place to go, and they don't.
Right. Let's do this. Let's flip a bit here. Let's talk about family health centers. And I've learned a lot getting prepared for this podcast. And I know that you yourself have a role at the Family Health Centers Phoenix, but there's 6 other locations, and they're very diverse in what they do. And there's a lot of comprehensive services, medical-related services, health-related services that you all provide that our listeners may not know about. So if you could tell us a little bit about what's going on with the Family Health Centers. I think this might be around the 50th year.
It is, yeah. We're celebrating our 50th anniversary, which
tell us
is a big deal.
It's really, really an amazing community resource.
Yeah. So, like I said, we have multiple clinics. Our primary location, as well as our administrative offices, the mothership, as I like to say, is the Portland, the former hospital there. So, Family Health Centers is very anchored in the Portland neighborhood, but as you said, we have a number of satellite locations as well, and they're primarily scattered around the southern and western parts of the metro area. We served last year 39,000 unduplicated adults and children throughout the agency. Among those, 88% were living in poverty. So the vast majority of Family Health Centers consumers are living in poverty. 26% were uninsured, and we see people, regardless of their ability to pay, work very hard to enroll people in insurance when we can. We have people located because that's a very important aspect of us being able to serve them, but we don't turn people away if they're not insured or they cannot or unable to get insured. They can be served on a sliding fee to make sure that even people with very minimal incomes are able to access services there as well. We do see about 10% of our patients are homeless themselves, and I'll talk a little bit about Phoenix, but we offer a few of our clinics are specialty clinics that do some really cool things, and one of those is the Americana Community Center. I always like to put a plug in for them, and they serve immigrant and refugee populations there that would otherwise not have probably, the information or the receive kind of the cultural sensitivity and understand, that staff is really well versed in the complexities of immigration. And, when people come to a new country, they have to have certain immunizations and all of that. So that's a great resource. And one of the examples of our specialty services, we also have a West Market branch, which specializes in behavioral health for both mental health and addiction related services as well. And then, of course, Phoenix, where I've spent my almost past 16 years, is what's called a Healthcare for the Homeless project. And that means they're a recipient from the federal Healthcare from the Homeless program that we get grants to do specific programming for people who are unhoused. So that is the criteria to be seen there. And the services offered at Phoenix are very specialized for the unhoused. So we have a psychiatric nurse practitioner. We have medication assisted treatment for alcohol and drug use disorders there. We, of course, have primary health care. We have a dental clinic and a pharmacy, and all of those services are very integrated into social services as well. So we have social workers working in the clinic. From the moment you walk in, we have a peer support specialist in the lobby who helps greet people, answer their questions, put them at ease. We have a lot of people who are dealing with trauma and other issues that may make it very hard for them to be in a crowded waiting room. So we really, the social services are anchored there to meet people where they are. We also realize some people may not come in for services because it's hard for them to get there, or they've had traumatic experiences and they're afraid to. And we do medical outreach in the community. Like I said, there were some gifts to us from the COVID era. We had funds, and one of the things we got was a dream we'd had a long time of having a mobile medical unit. So we have a RV-sized vehicle now that's basically an exam room and lab on wheels, where our medical providers and social workers, can go out into places that may be hard to access Phoenix, and to outreach to people and start providing services for them and get them enrolled there. We have a respite program at the Hotel Louisville because, if one of us went and had surgery today, the hospital doesn't want to keep you. They want to send you home. And, luckily, most people have homes and people there to help take care of them to go to, but homeless people don't. And, they may need extra time to get better. So the respite program offered by Phoenix offers a space for people to discharge. They don't necessarily need a lot of medical attention anymore. They can do their ADLs, but they still need some medical follow-up. It would be very hard for them to go to a shelter where they may have to check in and out at certain hours. They may have to climb up on a bunk bed. They may have to share a bathroom with a bunch of other people when they may be like having to change colostomy bags or, things like that. So, the respite is basically kind of a safe and comfortable space for them to stay. The average stay, I think, can depend a lot. Like I said, some people are recovering from a surgery or something like that, and they may need a short stay. We have people that are going through chemotherapy treatments for cancer who may be staying, at different intervals so that they can recover from those treatments. Just all kinds of situations. The respite is designed for acute needs, so it's not like a nursing home where someone's going to live like, on an ongoing basis for like a chronic issue. It is, meant to be a temporary transitional space, but it is, healing. And we have medical staff come over, to see them, to make sure they have their medications, to visit them there. There's basically 24-hour support staffing there. So if they need to go back to the hospital or having any kind of issue, someone's there to help them at the time. So it really, we provide healthcare at Phoenix, but I think we provide healthcare plus. And then the other thing I've talked about that I've worked in, and that's my experience working with St. Vincent de Paul, is we do permanent supportive housing as well. And we have a saying, in healthcare for the homeless, that housing is healthcare, because it's very hard to be well without it. So since about 2008, Phoenix has been operating a permanent supportive housing program. We have a little over 100 individuals, I think, in there at the moment. The majority of them are chronically homeless, so that means they experienced at least a year of homelessness before they went in. All of them have been diagnosed with some form of disability, which is a requirement of HUD. The majority of them were patients at Phoenix themselves, and they are able to live in the community. They rent apartments, with vouchers, similar to how Section 8 would work. They have case management. They still have the ability to receive healthcare services from Phoenix. So we, integrate their medical and behavioral health care as part of their case management there. And, allow people who may have really struggled to exit homelessness otherwise to have a safe, stable place to live for really as long as they need it. And that depends. Like I said, there's a lot of diversity. Some people may move on and not need that anymore. And then a lot of folks we serve are older and they're dealing with some really severe disabilities, and they may need that for the rest of their lives.
Yeah.
Well, you guys do incredible work. You're saying 39,000 unduplicated folks in just the last year. And I appreciate you kind of giving our listeners the full kind of scope and range of what you guys do. I'd love to hear a little bit about the Common Assessment Street Outreach team. We had talked to Jennifer offline just about some of that, and I think that had I believe you had started it from scratch, maybe, or were a big part of launching that. It seems like it's needed, now more than ever, in terms of boots on the ground, people on the front lines. It seems like at least 4 out of 5 days when I'm driving on my way to work off Broadway, that there is always several cops with a big dumpster truck, and it's the same spot, and they're always kind of cleaning this area where it seems like there may be a lot of unhoused, camping out during that overnight stay. But it's interesting. I'm sure they get such a good view of what's going on in the city in terms of your Common Assessment Street Outreach team.
Sure. So Common Assessment is kind of born from what HUD calls coordinated entry. So HUD wants, they're providing money for communities like Louisville Metro to provide these housing and services that we've talked about in a lot of forms. And that coordinated entry is a mode to make sure everyone kind of has a central point of access to it. So that is the notion, and that's really mandated by HUD. So, for example, St. Vincent de Paul has a housing program funded by HUD, and part of their conditions of getting that is that they take our referrals through a coordinated entry. So for Louisville, it is the Common Assessment Team. That's kind of a unique name that we chose. And we did choose it to do it, as you said, on an outreach basis. We want it to be very accessible. So we do that a number of ways. We have an office at the Coalition for the Homeless where people go to get their shelter beds and information so they can access us there. Ever since the pandemic, we've included access by phone to that office as well. So that's big. But like I said earlier, people don't always come to you, and often the people that don't come to you are the most in need. So we've really invested a lot in making that infrastructure outreach based. And so we have 4 to 5 people at a time that are going out into the community. That includes going to the shelters. We go to St. Vincent de Paul every other week. We go to most of the shelters every 2 weeks, if not every week. We go to the day centers like St. John's Day Center and Up for Women and Families multiple times a week. And then we also go out into the streets, like you said. So we work in partnership. There's a few other outreach teams that also work in the community, so we spend a lot of time kind of working with them, hitting those hot spots. As you said, camps are getting cleared a lot, and that part of that is connected to House Bill 5 that we talked about earlier. And it's really changed. Like used to, like people would be more clustered in a certain area. For those of us who've lived here for a while, before the soccer stadium existed, there was a big woods, and that was called Campbell Camp, and that was a huge community. And when camp went away, that displaced a lot of people, and they kind of spread out through the city. But for years, that was an outreach hub. Like that was an essential spot, like Common Assessment or any of the outreach teams would go. The unique thing about the Common Assessment outreach team compared to the others, though, is our express goal is housing and identifying people for housing. So we do an assessment with someone. It is 16 core questions asking about their homeless experience, including different risk factors in terms of their medical and chronic health conditions, behavioral health conditions, including severe mental illness diagnoses and severity of illness, severity of substance use disorder, about their financial resources. Are they victims of trauma and abuse themselves? We ask about domestic violence, which is unfortunately a huge issue. And all of these factors kind of give a score that helps us understand like how at risk someone is. And we've had a few iterations of this tool over the years, and the current one we kind of adopted as a community, and we really came together and did some workshops with providers and consumers both to see what they thought was most important, engaging that. So that helps us. And then we spend a lot of time helping people deem they're eligible. Like I said earlier, to be in permanent supportive housing, you have to be diagnosed with a disability. A lot of unhoused people do have a disability, but they may not be treated for it. They may not be receiving benefits. So our work becomes engaging them in healthcare and engaging them in behavioral health care because, one, we want them to have the care we need, but also documentation of that is like part of their path to housing. We spend a lot of time, our outreach workers know the people in the community, and we document the time they were homeless because HUD often requires that and prioritizes that. So we use that to help identify who's out there, who's at most risk, and help them determine a path toward housing. Unfortunately, we're also rationing something that I really hate we have to ration as a society, and that's housing, because the demand always far outpaces the supply that we have available of it. So, that's part of the reason we're ranking and prioritizing people. And to me, that's kind of sad when I operate from the premise that housing should be a fundamental, human right. So, that's a big part of what we do. Just to help you understand the scope of it, and, we talked earlier about the expansiveness of homelessness. I maintain a master list of the people who are assessed. And I think since we've been doing this since 2014, it's probably getting somewhere between 15 and 20,000. I haven't checked the total number, but the active number of people, so people who are we've assessed who are still in the system, going to shelters, seeing outreach workers, there's about 1,500 households at a time on there waiting for housing. And, there may be, in a really good week, a dozen or so housing placements to offer them. Some weeks, there's not that much to give them. So it's, the demand is just really huge out there. And the people we see, we want to give them hope, but we also have to give them a realistic expectation is that it can take a long time, to make something work for them.
Well, Carey, you're thank you for what you do.
Yeah.
And the passion is coming through. Your passion for this work is coming through, and you're saving people's lives by the work that you do, literally saving people's lives and giving hope where there may not be hope. So thank you for that.
Yeah, thank you.
And I know that, the family health centers it's a nonprofit, so there's probably opportunities for people to donate. There's opportunities for people to volunteer. what's the best? Is the best way just to go onto the website and check it out, and or
Yeah, we're always happy to receive donations. Phoenix specifically does one every December that really helps pay for those things that grants don't pay for. So that's a great one to check out. We post on social media and try to get the presents out for that fundraiser. But that money goes to buy things that for example, someone may be going into an apartment for the first time and they're really bored and don't know what to do, and it's so quiet, and it buys them a TV because that's something you can't buy with a grant. And that may seem frivolous, but that can make all the difference in the world. It provides them with household items. So that fundraiser is a really big deal, and I would encourage anyone to contribute to that. Because we are a medical organization, a lot of the work does require skilled training, so we don't rely that heavily on volunteers, but there's a lot of great agencies in the community that do. St. Vincent de Paul is definitely one of those. I'm sure in the shelter and open hand kitchen, you look for volunteers, and that's just, I can say great things about that place, and that our consumers love going there. So I will put a plug in, there. Again, St. John's Center and up are just, they're huge hubs. They're great places for students that may want some experiential learning. They can do everything from make coffee to help people get mail there and get to know people and kind of see what challenges they're experiencing at unhoused, and get to see the human side of that as well. So I think there are a lot of great opportunities to get involved.
Yeah, there are, and I think and one of the best ways to reduce homelessness is to try to help folks not become homeless in the first place.
Yeah, and just by volunteering, people, like you said, there's stigma, there are things people don't understand, and they can see that there's not a one-size solution that fits all, that not all people are homeless for the same reason. It's the people we serve are individuals, and they all have their own story. And I think often one of the things that frustrates them the most is no one wants to listen to that, and just listening to them, makes a huge difference. I find we have people, that come into our office and they would love for us to house them today, and that's just something we're not able to do a lot. But just by listening to them talk about what's going on, and us to try to give suggestions and hope can change their day, from just saying, no, we don't have anything, go away.
Well, you've helped me and our listeners and Tony understand much better what Family Health Centers are doing here in Louisville. I'll be honest with you, I didn't realize the breadth and the size of the organization, the complexity and diversity of services that you provide to our community. And like I said, I mean, it's literally saving lives and doing God's work. And we appreciate all that you do and all that you the passion that you bring to what you do each and every day. It's not easy work. So thank you.
Thank you.